All right. Well, good morning, everyone, and thank you for joining the second to last installment of this academic year's NB Heart Center Cardiovascular Teaching Rounds. And once again, I'd like to invite participants from across the province as well as from PEI. I see a couple of names that I invited for the first time last night. So welcome, and it's great to have you on board. So in the spirit of these rounds, what we've tried to do is we've tried to pick topics that we could have sort of nice 20-minute presentations on, followed by 5 to 10 minutes for questions and answers. As people can see from the invite email, all of the previous talks have been recorded with the exception of one and have been loaded up onto our YouTube NB Heart Center CV Rounds channel. And at least the impression I've been getting is that people have been actually viewing these, which is fantastic. Feel free to subscribe to the channel, share the links, all of the above. This is really for everyone's consumption. And actually, a friend of mine last week was sharing these with his center in Winnipeg. So there's a lot of potential, obviously, when it comes to these rounds. I'd like to reintroduce Dr. Craig Brown. Craig is a senior colleague here at the NB Heart Center, and he presented a few weeks ago on hypertrophic cardiomyopathy, and specifically looking at the pathophysiology and some of the medical therapies. And the second part now is going to be looking at more of the invasive therapies for hypertrophic cardiomyopathy, with a little bit of an overview from his past talk. So this is almost like part two of a Law and Order cliffhanger, so to speak, Craig, and we've been waiting with bated breath, and here it is. Or maybe let's use something more current: Game of Thrones season 8. It better be better than Game of Thrones season 8. Craig, over to you.
Thanks, Ansar. Good morning, everybody. I'm just going to change that screen just a bit. Okay, so this is part two of our talk on hypertrophic cardiomyopathy. I don't have any financial disclosures to make. And if I can quickly recap what we talked about a few weeks ago. Part one, we talked about the genetics and the etiology of this disease, the molecular and cellular pathology, and how those lead to the clinical manifestations in natural history. And we also talked about non-medical therapy and pharmacological therapy. Today, we're going to talk a little bit more about pathophysiology, particularly about SAM. For a more fuller discussion of SAM, I'll refer you to Dr. Chris White's talk, Who is This Guy, Sam?, that is included in this YouTube series of lectures. But I'm going to talk a little bit about SAM just because it's a little bit different in this disease pathology. And then we're going to talk about invasive therapy for alveolar flow tract obstruction, which is one of the major pathophysiologies of this disease. And if I have time, I'm going to talk about therapies for ventricular tachyarrhythmias and heart failure, and also on what's on the horizon for this disease. Remember on our last talk, we talked about how the pathophysiologies lead logically to the manifestations that we expect. It's the pathophysiology of left ventricular outflow tract obstruction that we're going to be spending most of the time about talking today, and that's the one that we can address invasively for the most part. So talking a little bit about SAM. So SAM refers to systolic anterior motion of the mitral valve. And in this diagram, you see there's hypertrophy of the septum, and this anterior leaflet, the mitral valve, is moving anteriorly and in fact impacting on the septum of the heart. And this occurs usually in the very later parts of the systole, and it enhances or is the sole reason for the left ventricular outflow tract obstruction in some people. When that happens, the coaptation between the anterior leaflet and the posterior leaflet is impaired, and mitral valve regurgitation also results. Also, casting your mind back to our last talk, we talked about how the rule of thirds is an easy way to remember how this disease manifests itself. So there's 1/3 of people have a resting alveolar flow tract gradient, 1/3 have a provocable gradient, and 1/3 don't have any gradient. There's also a second rule that I tend to keep in my mind. It's not so strict. I call it the 50-50 rule. And that is, what I mean by that is that half of patients with hypertrophic disease plus asymmetric septal hypertrophy get SAM, meaning that just because you have hypertrophic cardiomyopathy and asymmetric septal hypertrophy, you don't necessarily get SAM. Important to realize that. And the other part of that 50-50 rule is that half of patients with hypertrophic cardiomyopathy and SAM may or may not have asymmetric septal hypertrophy. So you can get SAM with hypertrophs without asymmetry of the hypertrophy. You can have a global LV hypertrophy and still get SAM. So I sort of illustrate that in that there's two sort of entities and there's an overlap between the two of them. And it's important to realize this because it influences how we treat patients, particularly with invasive therapies. I'm not going to talk a lot about this, but it's a sort of an interesting sidelight in how the physics of SAM occurs in this disease. It's a little bit different than SAM with any other type of cardiac disease. And the interesting thing, apart from the actual amount of hypertrophy that is here, therefore bringing this septum closer to the anterior leaflet, the other part is that as flow increases around this bulge, it causes what's called an Venturi effect. And when there is high velocity, there must be low pressure. And so the pressure sucks this, or in mechanical engineering terms, lifts this leaflet towards the septum. But by and large, for the most part, the major pathophysiology of this is a drag effect where the blood just pushes the anterior leaflet this direction. When we talk about septal reduction, there's basically two types of therapies: alcohol septal ablation versus surgical myomectomy. I don't really want to put them in a competitive way because it's not necessarily competitive. The indications for both of them are about the same, so the guidelines will usually lump them together in terms of their indications. So really you need to have, of course, a gradient, an obstruction, so a resting or provocable gradient more than 50 is usually the limit. Patients have to be on optical medical therapy, and yet despite that have class 3 to 4 symptoms or exertional syncope. So those are the major indications for septal reduction therapy. Septal ablation is an interesting technique where you catheterize a septal perforating artery, a branch of the LAD, or the left anterior descending coronary artery. You can see the balloon is inflated, and beyond the balloon, ethanol is injected. The ethanol causes necrosis, an ethanol-induced infarction, and this area of the muscle shrinks and the obstruction goes away. Very interesting and effective therapy. And as time goes on, and centers that are very experienced with it, more safe and more effective, actually. The other therapy is septal myomectomy. And again, you have, I lost my mouse, there we go. There's a septum that's thickened, and then in myomectomy, the scalpel is introduced through an open aorta, through the aortic valve, and basically resects that portion of the septum to remove the alveolar flow tract obstruction. And if you, a view from the surgeon's perspective would be this. So this is the aortic valve leaflets held out of the way, and this surgeon is going to be cutting in this direction, excising this part of the septum. And an intraoperative view is this. This is the aorta, the aortic wall. And inside, you can see the aortic valve leaflets. They're pushed out of the way and thin and look fairly normal. Unfortunately, this doesn't quite project as well as I'd like, but there is a resection that has gone on right here. You can see there's a divot or a trough that's been formed by the resection leading to these specimens. And it's interesting to see these specimens. You can see the white part of that. That's a scar. That is occurring because the anterior mitral leaflet is hitting the septum with every beat, and it's caused a scar to form on the septum. People wonder if you're in a center that does both septal ablation and surgical myomectomy, how do you choose which patients get which? And there are some things that would lean you to one direction or the other. Of course, you need to have appropriate coronary anatomy for an alcohol septal ablation. So many people don't have a large or properly placed septal artery so that this procedure is not possible. If there are other surgical diseases or mitral valve abnormalities that require surgery, of course, septal ablation really isn't the answer. And ideally, a basal asymmetric septal hypertrophy. So that subtype of HOCM is the best one that would be treated with septal ablation. On the surgical side, we can also deal with mid-ventricular asymmetric septal hypertrophy. We can certainly deal with mitral valve abnormalities or when the etiology of the mitral valve regurgitation is complex and requires intraoperative assessment. If there's other surgical diseases, of course, surgery is the way to go. But patients need to be operable. So if the patients are very elderly or have many, many comorbidities, it may be that surgery is just not a very good idea. And again, septal ablation may be the best way to treat this. Over time, the results of left ventricular outflow tract interventions has improved. And so modern series provide excellent results. Unfortunately, and there never will be, a randomized prospective trial that compares these two methods. But I can tell you that the relief of the obstruction is excellent with both techniques. The symptom relief is very good. There is a small chance that a second ablation is necessary with alcohol septal ablation, so about 3 to 14% in the literature now. It's rarely needed with surgery. The procedural mortality from a procedure that initially had about a 10% mortality surgically, now in both interventional cardiology hands and in surgical hands, it's about 1 to 2%. So it's a very safe procedure. And interestingly enough, and in contradistinction to the statements I made, emphasizing the fact that therapy generally is regarded as symptom relieving therapy for this disease, more recent studies have demonstrated that the 5 and 10-year survival of patients going for septal reduction therapy, both septal ablation and myomectomy, have results with survival that approaches or matches age-related normals. So people that are enthusiastic about this approach are beginning to say things like, maybe this influences longevity as well. It's a topic for discussion, that's for sure. Having done a few of these surgeries, I have developed some clues to improve my results. I just want to throw those in. I make a great deal of use of the preoperative echoes, and I almost always get a transesophageal echo as well, even if the transthoracic echo is of good quality. And during my evaluation of that echo, I actually drag out the calipers and measure the depth and the length of my resection. So I know before the surgery exactly what I'm planning to do with that septum to the millimeter. I understand the degree of mitral valve regurgitation, the mechanism of it, how bad is the SAM. I make sure I know exactly where the papillary muscles are. Are they causing or influencing the degree of SAM or the obstruction itself? And what is my plan for those structures? Intraoperatively, I make a hockey stick aortotomy. By that, I mean a transverse aortotomy very close to the sinotubular ridge, and then deviating down into the left, into the non-coronary sinus, so that I can get very close to the septum and I can lift the anterior root out of the way and see even better. I usually place pericardial stays only on the right side and lift them and have them quite taut, so that rotates the heart to the left and also improves my exposure. The initial incision in the left ventricular outflow tract, the septum, is crucial. So this is the one that influences usually the result that you're going to get. So make it where you want to be and use that developing specimen that you're going to take to pathology to lengthen and deepen it as you go on. Once you've taken out that specimen, it's much more difficult to resect further tissue. Of course, intraoperative transesophageal echo is mandatory. You can't do the surgery without it. And it's important to check for residual gradients, mitral valve regurgitation, SAM, and also look for complications such as ventricular septal defects. Be prepared to go back on pump and do more and deal with mitral valve if you have to. And I've learned, having done these cases, how to predict what I'm planning to do on the SAM and the mitral valve regurgitation the patient has preoperatively. So if I'm concerned that myomectomy is not going to be enough. I'm already going in with a plan to do something more with the mitral maneuver, mitral valve itself. Things like plications and Alfieri stitches and mitral valve replacement even, and certainly dealing with any papillary muscle abnormalities. By plication, I mean this. So this is a cross clamp on the aorta. This is the surgeon's view. Looking down, this is the open aortic valve, and looking down into the ventricle. And this is the anterior mitral leaflet. This is a vertical plication, and this is a horizontal plication on the right-hand side here. And they're both done for slightly different reasons. A vertical one would be if you have a very broad and redundant mitral leaflet and you made a very big trough, you don't want that redundant tissue slipping into the trough. So you close it vertically. This is where you have a very long anterior leaflet, which is a fairly common occurrence in this disease. And this shortens the length of the anterior leaflet and helps prevent recurrent SAM. And this plication I've done many times. This one I have not yet had to do. We have a bit more time, so I'm going to talk a bit about sudden death in this disease. Remember that 1 to 2% of patients get this with this disease. Secondary prevention, that is in patients that have already had a sudden death episode, the implantation of an ICD is really straightforward. There's not much in the way of discussion that needs to happen, other than the patient needs to have a life expectancy of more than 1 year. If that's the case, then the patient should get an ICD. It's in the primary prevention aspect of this disease where there's a lot of controversy because it's hard to predict who's going to have a sudden death episode. There's been various risk scoring methods developed by different international bodies. They're not perfect though, and when you do look at the patients that get ICDs, only a small subgroup actually receive life-saving shocks, and many of them get inappropriate shocks. So I think we have some way to go in understanding how to predict which patients should get ICDs in the primary prevention module. End-stage heart failure awaits many of these patients, unfortunately, and heart transplantation is an excellent method to deal with this. In fact, the results of orthotopic heart transplantation in this subgroup are excellent, better than you would see with ischemic cardiomyopathy or non-ischemic but not hypertrophic cardiomyopathy. So the green line is the hypertrophs, and the 1 year survival, it's as good as the non-ischemics. And for the 5 year survival, it's actually excellent and better than any other type of cardiomyopathy. So definitely a route to go. Not often used, numbers are smaller, way smaller than ischemic cardiomyopathies, but that has to do partly with the prevalence of the diseases. In terms of durable mechanical circulatory support, not often used. There's anecdotal reports. There's no long-standing series. The difficulty arises in that many of these patients with end-stage congestive heart failure still have very small ventricles, and it becomes problematic using a mechanical support for those patients. On the horizon, there are some very exciting things on the horizon. I'm just about to finish here. But there are viral-mediated gene replacements and mutation silencing therapies such as short interfering RNA molecules that may make a great deal of improvement in the natural course of this disease. And I wanted to highlight one smaller molecule. It's a myosin ATPase inhibitor now being tested in mice. In this mice model of hypertrophic cardiomyopathy has reduced or prevented left ventricular hypertrophy, myocyte disarray, and cardiac fibrosis. These are the three keystone pathologies of this disease, and it's stopping it. In an open label trial of 11 patients with symptomatic hypertrophs, over only 12 weeks, it's resulted in a reduction of LVL flow tract obstruction, reduction in their symptomatology, and increase in exercise capacity. So very exciting. If these things work, we won't be doing myomectomies and septal ablations anymore. Let's hope so. Well, thank you for your attention, and I'm happy to answer any questions.
Answer, we can't hear you.
Thanks, thanks, Chris. Appreciate that. Thanks, Craig. Appreciate the talk, and thank you for kind of completing the series on hypertrophic cardiomyopathy. It was an excellent overview, both from a surgical and a non-surgical perspective. I would just ask if anyone has any questions to either unmute themselves. For instance, Sharif, if you want to unmute yourself, go ahead. I'll just start off with one question, or put something in the chat forum. The question I have for you, Craig, is this: post-operatively, I mean, you've done quite a few myomectomies over the years, and post-operatively, do you do anything specifically, and not necessarily while they're in hospital, but even after they go home, do you do anything specifically to assess the effectiveness of your myomectomy? I guess obviously we rely on symptoms heavily to determine the success of a procedure. But do you subject them to routine echoes and/or routine stress echoes? And then next, are you using, in addition to echoes, are you starting to use any other modalities for your preoperative planning? And by that, I'm referring to MRI and/or CT scan.
Okay, so I think that the evaluation of our invasive therapy begins actually in the operating room. And so the intraoperative transesophageal echo is essential. So that, but if you're happy with your intraoperative transesophageal echo in terms of the gradients, the mitral regurgitation and the SAM and so on, then usually what I do, I go by clinical symptoms for the first postoperative period in the hospital, and I do not get a in-hospital post-op echo, usually because the quality of the echoes aren't very good with all the air and the fluid around the heart. But we will arrange for an echo at 6 weeks' time, and I don't get a stress echo. I rely on exercise capacity and symptomatology for that aspect of that. So a straightforward transthoracic echo is what I ask for. In terms of preoperative evaluation, I do get MRIs occasionally, and that's in the setting where the transthoracic echo is not a good quality echo. It helps me judge. What I'm really looking for is the length of the septal hypertrophy. I'm really interested in the degree of whether it's global or how asymmetric it is, and where is the burden of the hypertrophy, because that influences whether or not they're a surgical candidate, number one, and number two, where should I make my incisions, and what's the chances that this is going to work. And I have those discussions with the patients and the cardiologists. For instance, my second last patient that I did had global left ventricular hypertrophy, a lot of SAM and severe obstruction. And I knew, and a very acute angle between the aorta and the mitral valve, and I knew that there really wasn't very much role for septal reduction. This patient needed a mitral valve replacement just to get that mitral valve out of the way, and that would relieve the obstruction. It wouldn't do, and as the obstruction has gone away, and it worked very well. So there are scenarios where you need to know where exactly that hypertrophy is, and sometimes MRI is the best way to do it.
Sharif, you want to go ahead?
Thanks, Craig. My question had more to do with the elderly patients that we see now that have echocardiograms and they develop basal septal hypertrophy, or a sigmoid septum, as it's often kind of referred to. Do you do have you seen much of this? Have you ever had to operate in that scenario? I've had a couple people where they've had some SAM. Usually it's elderly women who have small LV cavity sizes and a prominent septum, usually on the background of history of hypertension. It's not clearly in keeping with hypertroph, but have you had any success with that, or have you seen much of that?
That's a good question, Sharif. Thank you. I don't think those patients have hypertrophic cardiomyopathy. I think I agree with you there. And I don't know if there's a role for septal reduction therapy in those patients. I will say that on occasion, we have people come to the operating room, and I think all of us have seen this, with aortic valve stenosis. And when you take away the valve, you see a huge septum below it, and you wonder, well, that residual left ventricular outflow tract opening is smaller than the valve I'm going to be implanting. And in that situation, I resect some of the muscle. I don't think that is hypertrophic cardiomyopathy. I think it's just the way their hypertrophy from their aortic valve stenosis has manifested itself. And I don't know if I'm doing any good, but I do it. In terms of the patients that have chronic hypertensive therapy and get a sigmoid septum, I don't think that septal hypertrophy is really probably going to be helping those patients very much. I have not taken any of those patients to the operating room.
Chris, I'll ask you to do two things. Number one, obviously, question, and then maybe just a comment on your experience with during your fellowship with transplantation in these patients.
So, Craig, thanks for the good talk. My question related really to the decision making between septal ablation therapy and myectomy. My impression from the guidelines has always been that alcohol septal ablation was reserved for those patients we did not feel were good surgical candidates or we felt had prohibitive risk. Is that still the case, or is that evolving?
Yeah, I think that's evolving. In fact, the European guidelines are sort of saying, do what your center does best is probably the best way to answer that. And and taking into account the various features of that patient, whether one might lead more to one direction or the other. But if you have a center that does both very well, and it's a straightforward basal septal hypertrophy, either way is good.
Okay, thank you.
Chris?
Answer in regards to your question, I think as Craig already highlighted, the management of these people from an MCS perspective is very challenging for the exact reason that was already highlighted. Their LV cap, and this goes also for any of the infiltrative cardiomyopathy. So the patients with amyloid and things like that. If you put a durable VAD in them, you have a very hard time filling the device. So either the VAD is set too high and you're sucking the septum down and having PI events and flow events, or if you set it too low in order to actually get it to fill, then you're not actually getting an adequate cardiac output. Their LVEDP is still high and you haven't done them any favors. So they can be very challenging patients to manage with a durable VAD. That being said, I think they're reasonable transplant candidates if you can get them at a stage where they've clearly are in the burnt out phase of their disease and meet indications, but haven't progressed so far as that they need mechanical support. We did bridge a couple people that presented in shock with this type of pathology with central bivads, but they were really rocky to manage until to transplant, and we lost a couple for those reasons, that they're difficult MCS patients to manage.
Thanks, Chris. Last question, Craig, from the audience. Is there a certain weight of the specimen? They mentioned about 10 to 12 grams in the literature for sort of resection success. Do you use that ever, or is it pretty much a feel thing? I've seen when you've done these cases with me, you kind of stick your finger in, not only to be able to see whether or not it passes, but also to feel, the thickness of the residual septum. Just a couple of thoughts on that front.
Yeah, no, I don't think there's any logic to resecting a certain weight. Every patient is a different size, and every septum is a different thickness. You do what you need to do to relieve the obstruction, hoping that, and our goal is to get a gradient that's less than 5. So you need to resect a lot, and if it, so it could be 5 grams, it could be 20 grams, who knows? I don't think restricting ourselves to 10 to 12 makes any sense whatsoever.
Right. Well, Craig, on that note, I would like to thank you for for your talk and for your time. Next week, Dr. White will present on cardiogenic shock, and we'll provide an overview. And that will be our last session on the 24th of June. Thank you once again to everyone for joining. I will post this lecture on YouTube in the upcoming few hours. In the interim, stay safe and enjoy the beautiful weather.